Hello everyone. Continuing the next topic. In last we studied extravasation mucosal, which was more common in young individuals. Now there is a retention mucosal, which is more often occur in older patients, and location is oral cavity such as floor of the mouth and inside of the cheek, and microscopically there is a mucus filled cyst completely lined by cylindric, cuboidal or flattened epithelium. Next is necrotizing cyanometaplasia, and it's a reactive condition involving minor or less commonly major salivary glands. It's a reactive condition and involves the minor salivary gland mostly, and it may be confused histologically with squamous cell carcinoma or mucoepidermoid carcinoma, and it usually presents as ulcerating lesion of the hard palate, which is characterized by vascular proliferation, prominent inflammatory infiltrate, partial necrosis, and associated with regeneration and squamous metaplasia of the adjacent ducts and SNI. It is confused with carcinoma because there is a ulcerating lesion, and next thing is vascular proliferation, other is partial necrosis, and there is regeneration and squamous metaplasia. Its pathogenesis is probably ischemic vasculitis and other primary vascular disorders. Now, tumor and tumor-like condition of squamous surface epithelium. Intraepithelial squamoproliferative lesions. There is a leukoplakia. Leukoplakia means a white patch or plaque not less than 5 mm in diameter, and it cannot be removed by rubbing. Most common location of leukoplakia is buccal mucosa and tongue. Other terms which are used as leukoplakia is keratosis, squamous hyperplasia, verrucous hyperplasia has been used interchangeably. When dysplasia is present, there is grading, which is mild, moderate and severe, and there is a squamous carcinoma in situ and therefore grouped as other sites. Severe dysplasia are the same for other mucous membrane, which is carcinoma in situ, epithelial disarray with full thickness atypia. There is distortion of the epithelium and full thickness atypia is there. No flattening or horizontal elongation of surface layer, and a basement membrane that appears intact in routinely stained section. As we have seen, in situ is basement membrane intact. This figure is showing the mild dysplasia, almost looking like normal, and it may be missed on the microscopic diagnosis. And it is a moderate dysplasia, slight disarray and slight atypia on the cells. Now it is a severe dysplasia. Basement membrane is intact and disarray of the epithelium, and there is a severe atypia. Okay. Oral intraepithelial neoplasia grade 1, it is equivalent to mild dysplasia. Grade 2 equivalent to moderate dysplasia, and grade 3 equivalent to severe dysplasia or carcinoma in situ. Okay. Immunohistochemically, we can distinguish between keratosis without and with dysplasia. In without dysplasia, there is a expression of keratin 19, P53 and proliferative related antigens such as Ki67. Ki67 most consistent with proliferative index and grading of the dysplasia. And severe dysplastic changes are much more likely to be present in lesions with clinical appearance of erythroplakia than those of homogeneous leukoplakia. It means erythroplakia shows more dysplastic changes when compared to leukoplakia, with erythroleukoplakia occupying the intermediate position. It means dysplastic conditions are more in erythroplakia, then there is erythroleukoplakia, and after that there is a homogeneous leukoplakia. There is also a correlation between the location of the leukoplakia and chance of finding dysplastic changes microscopically. The probability of dysplasia is much higher for lesions located in the floor of the mouth. It means if lesion is in the floor of the mouth, there is a chances of dysplasia is more. The most important issue concerning this group of lesion is likelihood of them evolving into invasive carcinoma of either squamous or varicose type. Next is oral and oropharyngeal lesions and human papilloma virus. The oral cavity can be the site of a variety of human papilloma virus related lesions, some of which are microscopically and very analogous to those located in genital tract. These include focal epithelial hyperplasia, verruca vulgaris, condyloma acuminatum, squamous papilloma. Benign lesions are associated with HPV 2, 4, 6, 11, 13 and 32, and malignant one are 16, 18 and 33. Benign are 2, 4, 6, 11, 13 and 32, and malignant are 16, 18 and 33. HPV detection are the poorly differentiating non-keratinizing squamous cell carcinoma of the oropharynx. There is a non-keratinization and it is poorly differentiated. Now this is the poorly differentiated basiloid appearing cells with a focal keratinization at places are typical of HPV related oropharyngeal squamous cell carcinoma. HPV positive oropharyngeal cancers are more likely to have a basiloid morphology as shown in the figure, and they have cystic lymph node metastasis. Favorable response to chemotherapy, chemoradiation, both are response good. Much improved survival compared to conventional squamous cell carcinoma of the head and neck, even though looking like a poorly differentiated, but it is more favorable. Okay. Next is hairy leukoplakia. Previously, it was believed to be associated with human papilloma virus, but now it is believed to be associated with Epstein-Barr virus, lytic infection, and lesion develop in patient with HIV infection, characteristically located along the lateral edge of the tongue. And microscopically, it shows parakeratosis, acanthosis, intranuclear inclusions, and associated ballooned or ground glass cytoplasm. High incidence of superinfection by Candida, as there is a occur in HIV patients. This is a diagram figure showing the hairy leukoplakia. There is, as we can see, the prominent ballooning of the squamous cells in the upper half of the epithelium, associated mild inflammation in the underlying stroma.